Thank you very much. I think that's the last time I get to ring the bell. That's harder to give up than anything else. Anyway, thank you very much for coming back. Now we get to have the pneumococcal session, which is near and dear to my heart, and Dr. Lee will introduce the session.
Thanks very much. And so instead of Chip being the last person, I am the last person. Where's Chip? There he is. So I'm really pleased to be up here introducing this work group. We have fantastic work group members. So I'm sad to say that Nana's leaving our work group, but I'm hoping we can kind of keep her enmeshed in this for a little while longer. And Paul Hunter, fantastic CDC leads, Tamara Pilishvili and Almia Metanak, who you'll hear from later today, as well as really fabulous liaison representatives and consultants who have contributed a lot and actually have been teaching me a lot, and our ex officio members as well. So these are our terms of reference. We're planning to, our work group has to review the current data on efficacy, effectiveness, immunogenicity, and cost effectiveness of pneumococcal vaccines. We are reviewing current recommendations, considering the up-to-date evidence, including epidemiologic studies, and assessing that strength of that evidence. And finally, revising or updating recommendations for pneumococcal vaccine use as needed. So you'll see here where we started in 2000 with a recommendation of PCV7 use for children. That was replaced by PCV13 in 2010. In 2012, the work group, ACIP recommended PCV13 for individuals with immunocompromising conditions. And in 2014, there was a recommendation for PCV13 in series with PPSV23 for adults 65 and older. Currently, we are evaluating the use of PCV13 in adults 65 and older, and the rationale for that is that in 2014, when ACIP recommended PCV13 plus PPSV23 for adults over 65, the thinking was that short-term, the recommendation was needed because while the indirect effects had decreased vaccine-type IPD, there was still a significant burden of pneumonia, and especially among the older adult population. However, there was a recognition that the long-term public health benefits were expected to be limited because of the anticipated continued indirect effects from pediatric PCV13. Therefore, the recommendation was made in 2014, with a commitment to reevaluate this policy 4 years later and revise as needed, and that's where we are in 2018. The reevaluation of PCV13 for adults has included the following tasks. We're monitoring pneumococcal disease, including both invasive disease and non-invasive pneumonia among adults 65 and older, evaluating the impact of direct and indirect effects on pneumococcal disease among adults 65 and older, and then continuing to monitor vaccine safety. So just to reiterate that this set of recommendations is, I'm hoping that's not my phone, I apologize. You can turn it off. Is that the complexity of the recommendation. So in 2012, you can see here that for patients who are considered immunocompromised with functional or anatomic asplenia, or for those with cochlear implants or CSF leaks, clearly there's a recommendation to continue PCV13 use in adults 19 and older. In addition, in 2014, the recommendation for PCV13 at 65 and older was recommended for these two groups, and this is what we're really focusing our review on. So in the past, we've presented on nasopharyngeal carriage before and after PCV13 introduction in the over 65 population to identify serotypes circulating in the community. Of note, for kids under 5 years of age, PCV13 serotype carriage had declined from 8% in 2011 to less than 1% in 2017, while overall total carriage remained about the same at 30% in the young kid population. For adults 65 and older, it's a little bit different. We have seen declines in PCV13 serotype carriage. It was estimated to be about 0.2% in 2015 to 2016, but overall the strep pneumo carriage rate is also quite low at 1.8%. We looked at PCV13 coverage in adults, and for adults 65 and older, the coverage was increased to about 40% through 2017, were the most recent estimates that were presented. And for the 19 to 64-year-old population with other PCV13 indications, coverage is lower and does vary by indication, and I think this is important for us to consider given the complexity of the recommendation already. PCV13 type IPD has declined in all age groups from 2007 through 2016, as many of you know. Overall, and PCV13 type IPD incidence in the adult population 65 and older also declined by 40% and 68% respectively, but then it plateaued from 2014 to 2016. So at the February meeting, a mathematical model was presented to estimate the contributions of a direct versus indirect effects of PCV13 on the trends in IPD among adults 65 and older. And the model estimated that 580 IPD cases were prevented since 2014 among the over 65 population in the U.S., with those benefits decreasing over time due to herd immunity. PCV13 effectiveness against IPD, PCV13 type IPD was about ranging from 47% to 65% in studies that were presented in February. These confidence intervals overlapped with the capita PCV13 efficacy estimates of about 75% against PCV13 type IPD. And then we have looked at PCV13 effectiveness against PCV13 type pneumonia, and it was presented to be approximately 73% in a test-negative case control study design that was presented again in February. Those confidence intervals overlap with our other prior estimates of PCV13 efficacy of about 45% against PCV13 type pneumonia. So for today, with that overview of what we've done to date, wanted to highlight the 4 topics you'll hear about: the safety of PCV13 in adults 65 and older by Dr. Shimabukuro, pneumococcal pneumonia burden and PCV13 impact among adults 65 and older in Louisville, Kentucky, Dr. Sweaterlow, pneumococcal carriage, invasive disease, and hospitalizations following community-acquired pneumonia among Native American populations from Dr. Hammett, and racial disparities in invasive pneumococcal disease and PCV13 impact, as well as an overview of the evidence to recommendations framework for our review for this PCV13 recommendation for adults 65 and older by Dr. Madanak. Just as a reminder, this is going to be a challenging question to address, so we're asking our committee members to think about what additional evidence might be helpful for decision-making with regard to continued use of PCV13 in the immunocompetent adult population with or without chronic conditions that are 65 and older. Thank you.
Good morning. Like Dr. Lee said, I'll be presenting on the safety of 13-valent pneumococcal conjugate vaccine in adults age 65 and older. I'll briefly cover the background on PCV13 recommendations in adults, very briefly, because I don't think I need to repeat what Dr. Lee just said, and then present the findings of a recent VAERS review in adults 65 and older, and then present the results of a vaccine safety datalink study. I'll skip to this slide, which is a reference slide showing the August 2014 recommendation and some of the specifics for pneumococcal vaccine naive persons and those previously vaccinated with PPSV23. So the safety, I think this is an older presentation, but than the one I was going to present, but it'll be just fine. The safety of PCV13 was evaluated in pre-licensure randomized controlled trials in PPSV23 naive and PPSV23 experienced adults aged 50 and older. And the most common adverse events did not differ between the two vaccines. There's actually been 2 post-licensure studies of adults age 50 and older, and the findings from those observational studies are reassuring. And then there was a VAERS review of reports in adults age 19 and older from 2012 to 2015. Injection site reactions and fever were most commonly reported, and the safety profile was consistent with safety data from pre-licensure clinical trials. So moving on to the VAERS review. So the objective of the VAERS review was to describe the safety profile of reports submitted to the Vaccine Adverse Event Reporting System following PCV13 in adults 65 and older. Just to remind you, VAERS is our National Spontaneous Reporting System. It's co-managed by CDC and FDA. Its strengths are that it can rapidly detect safety signals and can detect rare adverse events. It's subject to the limitations of spontaneous reporting or passive surveillance, which means generally we cannot assess causality from VAERS data alone. So we searched the VAERS database for PCV13 reports from August 2014 through December 2017, and we restricted our search to U.S. reports in adults age 65 and older. Serious reports were defined as those documenting death, life-threatening illness, hospitalization, prolongation of hospitalization, or permanent disability. Signs and symptoms of adverse events are coded using medical dictionary for regulatory activities or MEDRA preferred terms, which are not mutually exclusive, which means a single report may be assigned more than one MEDRA PT. We conducted descriptive analysis, clinical review of reports of selected pre-specified conditions, which included Guillain-Barré syndrome, anaphylaxis, and death. And our FDA colleagues conducted empirical Bayesian data mining to detect disproportional reporting. So in our review, we identified 5,822 VAERS reports in adults 65 and older following PCV13. 75% of these reports were in females. 6% of reports met the regulatory definition for a serious adverse event. The median age was 72, but remember, it was the bottom end was 65. The median onset interval was the day after vaccination. And in 72% of these reports, PCV13 was administered alone. In reports documenting co-administration of vaccines, high-dose inactivated influenza vaccine, zoster vaccine live, and Tdap were most commonly co-administered with PCV13. These are two tables showing the most common signs and symptoms in reports to VAERS following PCV13. On the left-hand side, you have the reports where PCV13 was given alone. Again, that was 72% of reports. And on the right, where there are other vaccines, we're showing these two tables basically to show you how similar they were, even in individuals who received co-administration of vaccines. And following PCV13, injection site reactions and symptoms consistent with systemic reactions were most commonly reported. Move on to clinical review of reports. We identified 39 Guillain-Barré syndrome reports. The median age was 73. The median onset interval in days was 11. And just to remind you, the biologically plausible risk window we use for Guillain-Barré syndrome is 0 to 42 days. In 23% of reports, there was documentation of a viral respiratory illness 2 to 4 weeks prior to the onset of GBS symptoms. And viral URIs are a known risk factor for Guillain-Barré syndrome. 67% of these reports met the Brighton collaboration criteria for Guillain-Barré syndrome. In 64% of the reports, PCV13 was administered alone. We identified 4 reports of anaphylaxis. In one report, the case report met the Brighton collaboration level 1 criteria, which is the highest level of diagnostic certainty. This was in a 94-year-old female who received only PCV13 and within a few hours began to experience symptoms of anaphylaxis. The remaining 3 case reports had insufficient information to confirm a diagnosis to apply the Brighton collaboration criteria for anaphylaxis. We identified 26 reports of deaths. In 25 of these, we were able to confirm that a death occurred through an autopsy report or a death certificate. Median age was 80 years. Median time from vaccination to death was 13 days. In 81% of these death reports, PCV13 was administered alone. These were the causes of death among the verified deaths after PCV13 in adults 65 years and older reported to VAERS. Cerebrovascular accident, septic shock, coronary artery disease, chronic obstructive pulmonary disease, and some other heart conditions were the most commonly were the most common causes of death among these verified reports. And in the review, we did not identify any unusual or concerning patterns or any unusual or concerning clustering in the post-vaccination period. Empirical Bayesian data mining did not show any unexpected disproportional reporting for PCV13 MEDRA-PT pairings for adults 65 and older compared to other vaccines in that age group. So in summary, we identified 5,822 reports during the analytic period. Most reports, 94%, were non-serious, and this is similar to other vaccines given in this age group. The most frequently reported adverse events were injection site reactions and fever. There were no unexpected data mining findings, and no new safety signals or unexpected patterns were observed. Just to note, during the analytic period, approximately 29 million PCV13 doses were distributed for the 65 and older U.S. population, and that data comes from the manufacturer. So moving on to the Vaccine Safety Datalink study. Vaccine Safety Datalink, or VSD, is our large link database system that has data on over 10 million persons per year. We conduct active surveillance and do epidemiologic studies in the VSD. It links vaccination data to health outcome data. So vaccination records, health outcomes, and patient characteristics are all linked using a unique ID. The objective of the VSD study was to examine a large cohort of adults aged 65 and older for evidence of an increased risk of adverse events requiring medical attention following vaccination with PCV13 compared to PPSV23. This is a cohort study. It involves 6 VSD sites. The study period was January 1, 2011 through September 30th, 2015. Exposed doses were first dose of PCV13 received by active members 65 and older during January 1, 2015 through August 15, 2015. Unexposed doses, which you can consider control doses for the purpose of this vaccine, were first dose PPSV23 received by active members of the same age group during January 1 to August 15 of each year between 2011 and 2015. Outcomes included cardiovascular events, Bell's palsy, Guillain-Barré syndrome, syncope, erythema multiforme, thrombocytopenia, cellulitis and infection, allergic reactions, and anaphylaxis. Possible confounders that we controlled for were age at vaccination, sex, VSD site, healthcare utilization, Charlson morbidity score, which predicts one-year mortality, concomitant vaccination, and calendar month. This is the study population, VSD sites, and the doses. As you can see, there were just over 232,000 PPSV23 doses and just over 313 PCV13 doses. So this is the results table, which is a kind of a complicated, busy table. But if you focus, moving left to right, in the first column here, you have the adverse events and some of the breakdown of these sub-events here. Then in the next 2 columns, you have PPSV23 and PCV13 adverse event counts. And then if you focus on this highlighted, well, focus on the circled column there, the adjusted relative risks and confidence intervals. And you'll see the relative risks for all the pre-specified adverse events. None of them actually reach 1 except for anaphylaxis. And for anaphylaxis, 1 is in the 95% confidence interval. So there's no increased risk for medically attended adverse events following PCV13 compared to PPSV23. In fact, statistically, there appears to be a protective effect for some of these outcomes. A sensitivity analysis was conducted and included the alternate comparison groups those that received PPSV 23 during 2015 and those that received it from 2014 through 2015. So this was just looking at PPSV doses in more recent seasons compared to the more broader historical period that was used for the main analysis. The sensitivity analysis did not affect the overall results. So the results of this VSD study of PCV13 safety in adults 65 and older do not support an increased rate of adverse events for those adverse events studied following PCV13 compared to PPSV23. And the findings should provide reassurance regarding continued use of PCV13 in this age group. Thank you.
Thank you. Are there questions? I guess not. I guess we'll move on to the next presentation on pneumonia incidence in the United States. Dr. Swerdlow. Thank you.
Well, thank you so much for inviting us here to speak. It's really a pleasure to be back at CDC. I see so many of my friends and colleagues, so it's really a pleasure to be here. Today, we're going to be discussing why during the ongoing review of the 2014 age-based recommendation for adults over 65, CAP incidence is critical for understanding the burden of disease and the cost-effectiveness of the pneumococcal vaccination program. Cost-effectiveness calculations in 2014 were based on an assumed hospitalized CAP incidence rate of 1,375 per 100,000 based on administrative claims data. And then there are also two previous population-based surveillance studies, the EPIC project from CDC and the Ohio study, which estimated that the incidence of hospitalized CAP to be 900 to 1,000 per 100,000 for adults greater than 65. So we conducted active population-based surveillance for hospitalized CAP and determined the proportion of CAP due to PCV13 serotypes. And we hope to show you by the end of this talk that we determined that the incidence of CAP is higher than previously recognized, that PCV13 serotypes persist, that there is evidence for direct impact of PCV13 in adults greater than 65, and that disparities in vaccine uptake are evident. So today, during my talk, I will describe the incidence of hospitalized CAP. Then we'll discuss PCV13 serotypes in CAP patients and PCV13 impact. And then we'll discuss disparities in PCV13 uptake. So first, we'll talk about the incidence of hospitalized CAP, looking at the Louisville pneumonia study. So the Louisville pneumonia study was prospectively enrolled all adults greater than 18 living in Louisville, Kentucky, who were hospitalized with CAP, and it was based on clinical and radiographic criteria. All 9 adult acute care hospitals were included, so we had the full catchment in that area. We estimated incidence of CAP during a 2-year period, June 1st, 2014 through May 31st, 2016. And for all patients with CAP, we performed PCV13 serotype-specific urinary antigen detection assay to determine if they had PCV13 serotypes as the cause of their pneumonia. So this slide shows the incidence of hospitalized CAP by age group in the Louisville study. And overall, the incidence was about 700 for all persons greater than 18. But what we want to focus on is the over 65-year-olds. And for that, the incidence was 2,300 per 100,000. And as you'll recall, that's higher than was previously seen in the claims-based surveillance or in the EPIC or the Ohio study. So we thought a lot about why the incidence rates that we saw in Louisville were higher than the incidence rates in EPIC and in the Ohio community study. And so this slide shows the selection criteria as well as the 3 studies. And the first 3 selection criteria were not really substantially different in terms of incident rates between Louisville, Epic, and Ohio. But for HCAP, or healthcare-associated pneumonia, there were differences, as well as for immunocompromised patients. And by that, I mean that in Louisville, we included healthcare-associated pneumonias, but in Epic, those were excluded, and in Ohio, they were excluded. And for immunocompromised patients, they were included in Louisville, but they were excluded in Epic. So is that enough to explain the differences in incidence that we saw? Well, this slide starts off by looking at the incidence rate of hospitalized CAP in the Louisville study. So as you can see, again, it's 2327 is the incidence rate that we saw per 100,000 in the Louisville study. But if you applied the selection criteria that were used in the Ohio study and excluded HCAP, then you actually would have had an incidence rate in Louisville of 1,291, which is pretty close to what Ohio found with 1,000. In the same manner, if you applied the selection criteria that were used in the EPIC study and excluded HCAP and immunocompromised patients, then you would have gotten an incidence rate of 798, which is again very similar to the rates seen in the EPIC study. So we feel that the differences in incident rates can be explained by the inclusion of HCAP and immunocompromised patients in our study. Well, why is it important to include HCAP and immunocompromised patients in estimates of CAP incidence? Well, both HCAP and immunocompromised patients make up a substantial portion of CAP hospitalizations. And the updated guidelines no longer recognize HCAP as a relevant clinical entity separate from CAP. Immunocompromised patients have always been at highest risk of pneumococcal disease. And finally, in the next few slides, we will show you that there's a similar proportion of PCV13 serotypes identified in adult HCAP patients and in immunocompromised patients as compared to patients without CAP or immunocompromising conditions in a study that we'll be discussing very shortly. So the next section, I'm going to be talking about PCV13 serotypes in CAP patients and PCV13 impact. And we'll be using data from the multi-site SSUAD study and the Louisville Pneumonia study. Now, I talk about these as being separate studies, but in fact, the multi-site UAD study is really just an expansion of the Louisville project. And so we expanded SSUAD surveillance to 21 hospitals in 10 geographically dispersed cities across the United States. And we evaluated the percentage of hospitalized CAP in U.S. adults caused by PCV13 serotypes over time. The time period is slightly different because we were able to include surveillance for a 3-year period from October 2013 through September 2016. So this slide shows the percentage of CAP caused by PCV13 serotypes from the entire 21 hospital surveillance system. And so as you can see, on the left is patient group, so all HCAP, no HCAP, immunocompromised, immunocompetent. And then you can see the percentages of CAP caused by PCV13 serotypes for over 65 and for 18 to 64. And so as you can see, the numbers are all fairly consistent. And there are not any great differences between the percentage positive for HCAP and no HCAP, or immunocompromised and not immunocompromised. So therefore, excluding HCAP or immunocompromised patients excludes potentially PCV13 preventable adult CAP disease burden. Now we're going to talk a little bit about measuring the impact of PCV13. And so we're going to again use the proportion of CAP caused by PCV13 serotypes from both studies that we just mentioned. For PCV13 coverage For the numerator, we're going to be using monthly administrative claims data projected to national estimates from IQVIA, which was formerly IMS Health. And the denominator will be the U.S. Census data. So any impact against PCV13 type CAP seen among adults greater than 65 who would have direct vaccination impact, but also indirect impact from the pediatric program, but not in the 18 to 64 at-risk group, which would only have indirect impact or serve as a control group. So any differences would be assumed to be direct impact above and beyond the pediatric indirect effects. And I'll show you what I mean in 1 second. So this slide shows the percentage of adult CAP caused by PCV13 serotypes over time. And on the left, you see it goes from 0 to 10%. The red line is 18 to 64 at risk, what we're thinking of as being a control group. And the blue line is 65 and above. And so there's a couple of things to see in this slide. One is that for 18 to 64 at risk who don't get vaccinated, the percentage of CAP that's due to PCV13 serotypes has not changed. For and the time periods I should mention is October 2013 to September 2014, which is when the ACIP recommendation came out. So the first point is pre-recommendation. The blue line is 65 plus, and there was a substantial difference and decrease in the percentage of CAP caused by PCV serotypes over time. So we think that the difference seen is equal to what the direct impact of vaccination is. The other thing to see from this slide is that there is a plateau of about 5% for 18 to 64-year-olds for PCV13 serotypes. This addition to this slide just shows you what the uptake was for these different groups. So for the 18 to 64, there was not very much uptake, obviously, because it's not recommended. But for the over 65s, it increased during this time period. Now, the Pneumococcal Working Group asked us if we could present this same data, really, but instead of percentage in terms of incidence. So this is a complicated slide, but it is an attempt to describe for you how the incident rates have changed per year. And for this study, we only used the Louisville data. We couldn't use the entire 21 hospital data because we only had incidence data from Louisville. So year one is June 2014 to 2015, and that includes the time period of the ACIP recommendation. Year two is after the ACIP recommendation. And you can see on the left there's 65-year-olds and 18 to 64-year-olds, and then 18 to 64-year-old at risk. And within each of those, we show all-cause CAP and PCV13 type CAP. And what you want to focus on is the far right, which is the percent relative reduction. So from year one to year two, for PCV13 type CAP, there was a 31% reduction, which was statistically significant, in the incidence of PCV13 type CAP for over 65. But for 18 to 65-year-old all and 18 to 65-year-old at risk, there was no significant difference. So to us, this is more evidence that there was a direct impact of vaccination. The other thing interesting about this slide is the incidence rate per 100,000 of 76 that you can see for year two of PCV13 type CAP. So is that a lot? Is 76 per 100,000 still remaining a lot? And for us, the answer is yes. That's in the same ballpark as influenza hospitalizations per year. So we think that that's still a significant burden. So finally, we want to talk about disparities in PCV13 uptake. And we examined disparities in PCV13 uptake among adults greater than 65 by merging the IQVIA claims data with Experian consumer view sociodemographic data. And I'm not going to go into all the methods for this. We can happy to discuss it afterwards. It was actually kind of interesting. But we were able to match 60% of the claims data information from IQVIA. We looked at income level, decile, race, ethnicity, urban and rural versus suburban, and education level. And overall, PCV13 uptake was 43% by the end of November 2017. So this slide shows that the PCV13 uptake is considerably lower among older adults who are in poverty or African American. So on the left, you can see the uptake by decile of annual household income. And so for the lowest decile, the uptake of PCV13 was 31%, but for the highest decile, it was 54%. So that's a pretty substantial difference. The same is true for uptake by race, ethnicity. For Hispanics, blacks was 30 to 36%. For whites, was 46%. We also showed very similar results for education level, high school or not, and for being in a rural area or an inner city versus being in a suburban area. So clearly, there are very large disparities in uptake of PCV13. Well, why does that matter? Well, back to the Louisville pneumonia study, we were able to show on the far left, you can see it's a heat map of Jefferson County, Louisville, where the most cases of CAP are in red. And in the next two pictures, you see the same kinds of heat maps where red is equal to high poverty or red is equal to a higher proportion of African Americans. So in the areas where you're getting cases is the areas where there's high poverty and a high proportion of African Americans, is the very areas where we're seeing disparities. So in summary, the Louisville study showed high incidence or burden of 2,300 per 100,000 in hospitalized CAP in persons over 65 years old. We showed a significant reduction in vaccine type CAP in persons over 65 following PCV13 introduction in adults, but vaccine type disease still does persist. In contrast, during the same period among 18 to 64-year-olds where PCV13 was not recommended, vaccine type remains stable and in fact has plateaued. These findings suggest a direct impact of PCV13 on vaccine type CAP beyond pediatric indirect effects. PCV13 uptake in greater than 65-year-olds has increased steadily since the 2014 age-based recommendation to 43% by November 2017. Continuing PCV13 vaccination in adults greater than 65 will allow more time to increase uptake in the general population and address the existing disparities in PCV13 uptake in the very communities at increased risk for pneumococcal disease. Thank you.
Thank you. Do we have questions? Dr. Romero.
Very nice presentation. So did you run your heat maps using Latinos, Hispanics, as you did for our African-American population?
There's a paper that's going to be coming out that looks at even more details on this area, and they actually divided the census tracts into census groups and did a lot more a review of this, and I would be happy to provide you with the results of that. But we looked at several different groups, as well as looking at severity, and actually in those areas there was more severe disease and more likely to have mortality as well. So,
Dr. Szilagyi.
Thanks for a very nice presentation. Two questions. Do you have CAP hospitalization rates by race and ethnicity? You presented the vaccine uptake, but the pneumonia rates comparing over 65 and below 65?
Well, we have that from the
Louisville study.
Yeah, I could certainly forward you the information, but it should be in the paper as well.
And also, one quick question. In terms of the heat map, if you would just plot the population density, would it look the same?
Yeah, that's a good question. The thought was that the census tracts are all about the same population, So they didn't do it per population, but I think it would be interesting. It's a good question. I think it would be interesting to do it per population, not necessarily only by census tract. But the rationale was that they thought the census tracts were all about the same population.
Dr. Massonia?
Yeah, thank you, Dr. Swerdlow. That was a great presentation and very provocative, especially the data about the HCAP population. I guess one question is, does Pfizer have additional studies planned that are going to be available within the time frame for which ACIP is going to need to make a decision, or is this sort of the body of work that will be informative?
No, we have other, we're still collecting, this data and doing analysis. We're doing meta-analysis of serotype 3 effectiveness, and I mean, there are certainly other studies that we'd be happy to think about and discuss in October.
Other questions? Okay, thank you very much. Oh, one more.
Pat Whitley-Williams, the NMA. Do you have any data regarding where persons in the Louisville area actually get their vaccinations? In other words, do they get them from their primary care providers, or are they getting them from large retail pharmacies, or?
We do. I don't have the answers at the top of my head, but we went back to every patient during a certain time period and found out exactly what their vaccination history was, which was actually a lot more complex than you would have suspected. We had to call up insurance and talk to their primary care doctor, and that was presented, actually, the results of that analysis was presented last ACIP. But because of that, we know exactly where people were vaccinated, and we could provide that information. I don't have the information at the top of my head.
Also, what about there are hospital reminders, or that's not the correct terminology, but if a patient is admitted for anything, they will actually look at influenza and pneumococcal vaccinations prior to discharge. Do you have that information?
Well, we could certainly ask Louisville to let us know what happens in each of the 9 hospitals.
Thank you. What I'm trying to get at is where the possible intervention efforts could be applied, but thank you.
No, I think that's critical, and especially in trying to decrease some of these disparities. I think it's really important to think about how to reach certain populations, and I think that is a very important topic to think about.
Dr. Hunter?
I just had one comment about the hospital policies issue, is that at least in Milwaukee, and I heard other places, that there were hospital systems that decided to stop doing routine discharge pneumococcal vaccination with the introduction of the conjugate vaccine, because it was complicated, and also because Medicare stopped including pneumococcal rates on hospitalizations as a measure that they were measuring.
Dr. Paradiso.
Peter Paradiso. I'm a vaccine consultant now, including for Pfizer, where I lived for many years. And David, I was interested in your comment about the rate of PCV13 disease and the comparative cases per 100,000. And we're used to thinking, or anything anyway, about baby cohorts, which are 4 million a year, as opposed to a cohort of over 65-year-olds. And can you translate that into numbers of cases of pneumonia for over 65, or even the group of at risk, where if you were to reduce that 5% to 3%, or follow the same pattern, how big is that burden?
Well, that's a great question. I do have a slide that expresses that a little bit differently, but I think it might be worth going through. So what you're asking is basically how, 4.2% or 3.8% or whatever that sounds like a very small number. And why are we worried about 3.8% of all community-acquired pneumonia? But we think that it actually is a tremendous burden. And so this was a slide we actually prepared for a previous ACIP. But if you look at the bottom of the pyramid, you see that there's 49 million U.S. adults age greater than 65 years old. And so if you apply the cap hospitalization rate of 2,300 per 100,000, and then from Louisville, I didn't really describe this a lot, but the in-hospital and then 30-day mortality was 6.5% to 12.7%. And then if you say that cap that is PCV13 type is 3.7% in unvaccinated people, so that's a different number than we've been using, but it's among people who are not vaccinated. And then you use the results from the TND analysis that were presented last time, where you had a vaccine effectiveness of 72.8%. So when you translate that to the entire U.S. population and adults over 65, it's really a tremendous burden. And I think that's actually a very, very important point. So when you translate that, it's an absolute rate reduction of 62 per 100,000. The number of hospitalizations averted over 5 years, because we know that our vaccine works at least 5 years, is 137,000. So is that a lot? And the answer, in my eyes, is that is equivalent to what the averted hospitalizations in the influenza vaccine program. So, papers from CDC, which have talked about averted cases and averted hospitalizations, are somewhere in the ballpark of 8 to 20 to 40,000 hospitalizations per year averted. So 137,000 is in that same ballpark. And again, deaths, 17,000 over 5 years, I think that's a lot. So I think 3.7 or 4.2 or 5.1 doesn't sound like very much, but I think it actually does lead to a tremendous burden.
Thank you. Any other questions or comments? All right, Dr. Hammett.
Good morning. It's an honor to be here this morning to present data on pneumococcal carriage and disease in Native Americans on behalf of my colleagues at the Johns Hopkins Center for American Indian Health and our collaborators. My disclosures are that I have research grants to my institution from Merck, Pfizer, and GSK. And I'll be presenting today data on pneumococcal carriage and invasive pneumococcal disease that come from the Center for American Indian Health sites among Native Americans in the Southwest United States, as well as data from Alaska Native populations that have been shared by the CDC's Arctic Investigations Program. And I'll also share data on adult community-acquired pneumonia from the Southwest U.S. In order to understand and interpret vaccine impact, of course, we need to know about PCV13 coverage. The data here are for children are from the Indian Health Service Immunization Registry, and reports on vaccine coverage in the different Indian Health Service areas are available online. The data here are from Navajo, and you can see that coverage for the different age group and dose counts there is between 80 and 85%. Data from Alaska Native children show coverage actually a little bit higher than this. The Indian Health Service Immunization Registry doesn't currently differentiate between polysaccharide and conjugate pneumococcal vaccine, but we do have ways to estimate PCV13 coverage in adults. Among our study participants in 2015 to 2017, PCV13 coverage in those 65 and older was about 60 to 80%, so higher than what you see in a lot of the rest of the country. Up in Alaska, however, coverage among adults 65 and older was a little bit lower, up to 24% in 2016. So turning now to pneumococcal carriage data, this is from a study funded by Pfizer. Here you see PCV13 type carriage prevalence in the early infant PCV13 use era. The carriage prevalence for PCV13 types among children less than 5 years of age is shown in brown, and you can see that it declines from 12% when PCV13 was first rolled out in early 2010 down to 4% 2 years later. And then among adults, which is shown in the red line, You can see PCV13 type carriage prevalence decreasing from about 2% at the start of the study down to about 1% after 1 year of infant PCV13 use, and staying at around 1% through early 2012. We conducted a follow-up carriage study in 2015 to 2017, and here you see data in children less than 5 years of age. Data from the infant PCV13 era are shown in brown, and infant plus adult PCV13 era, that is the 2015 to 2017 study, are shown in the gold bar. Overall carriage prevalence was about 50%, and that was similar across the two time periods. PCV13 type carriage prevalence remained stable at around 4 to 5% between the two time periods. And the main PCV13 types in circulation now are 19F and 3. Before I go on to show the adult data, I just want to highlight a couple of key similarities and differences between the two different studies that we conducted. In the second study, we made a concerted effort to enroll adults. So we enrolled 300 adults into each of 3 adult age categories. And this is reflected in a much higher median age of adult participants in that second study. And we did this really to get a more robust understanding of what carriage in adults look like in the era of adult and infant PCV13 use. The second study also included OP swabs in adults, and we used sequotyping instead of Quellung for serotyping. Pneumococcal carriage prevalence in adults is shown here. Again, there are the data for the infant PCV13 era, the 2011 to 2010 period, 2011 to 2012 period are shown in brown, and the infant plus adult is shown in gold. Serotype for all types, you see that pneumococcal carriage ranged from about 6% in those 65 and older, and that's on the far right-hand side, up to around 11% in younger adults. And that was similar across the two time periods. PCV13 type carriage was around 1%, also similar between the two time periods. So we're not seeing a lot of PCV13 type carriage. When we did look at OP swabs and use of PCR on OP swabs, which is thought to be a more sensitive technique, the estimates of PCV13 type carriage did increase to about 3%. These are data from Alaska that were kindly shared by Mike Bruce at the CDC's Arctic Investigations Program. And here you see PCV13 type carriage in Alaska Native people. These are data from cross-sectional studies that have been conducted in Alaska Native villages annually for many years now. And you see a nice decline in PCV13 type carriage in children, which is in the yellow line, following PCV13 introduction in infants. And then among adults, you can see that carriage is low, around 1%. And these data from 2015 are prior to widespread use of PCV13 in adults. There was only one adult in this study who'd actually received a PCV13 vaccine. So our conclusions from the carriage data are that PCV13 type pneumococcal carriage in adults was very low following infant PCV13 introduction and remains low. I'll turn now to invasive pneumococcal disease data. The Center for American Indian Health collaborates with tribes in the Southwest and IHS facilities serving those tribes to conduct active population-based, laboratory-based surveillance for invasive bacterial disease, including invasive pneumococcal disease. This work's done on the Navajo Nation, which is shown in red on that map. And just for reference, the Navajo Nation, that's about the same size as the state of West Virginia. So it's a pretty large area, and the population's about 250,000. Identified pneumococcal isolates are sent up to the CDC field station in Anchorage for serotyping, and we conduct chart reviews to assess underlying medical conditions and vaccine history. And this surveillance system, as well as another one up in Alaska, both of which are comparable to the CDC's active bacterial core surveillance system, allow us to make comparisons on rates of disease between these different populations. On the left-hand side, you can see rates of disease in children less than 5. In the middle, adults 18 to 64. And on the far right-hand side, you can see rates of IPD in those 65 and older. And across these age groups, you can see that Native Americans and Alaska Natives continue to experience disease at rates 3 to 5 times higher than the general U.S. population, with most of that being attributable to the non-PCV13 serotypes. Despite that persistent disparity in disease, I think it's really important to note the tremendous impact that conjugate vaccines have had, especially in high-risk populations. So here you see the rate of PCV13 type IPD in Navajo children less than 5 years of age, starting on the left-hand side in the pre-PCV era, moving into the infant PCV era in the middle, and then the infant PCV13 era. And PCV use in children has virtually eliminated PCV-type disease in children. As has been seen in other populations, there have been indirect benefits as well in non-vaccinated age groups. And on this slide, you can see PCV13 type IPD incidence in 3 different age groups across the x-axis and in 4 different time periods. So in the red bars is the pre-PCV era, the blue bars are the PCV7 infant era, the brown shows the infant PCV13 era, and then the gold is infant and adult PCV13 use. And in each of the age groups, if you compare the pre-PCV era to the current adult plus infant PCV era, you can see there have been substantial reductions in PCV13 IPD incidence. When we look at the impact of the recommendations for vaccine use in adults and then compare the brown bars, which is the infant PCV13 era, to the gold bars, the infant plus adult PCV13 era, you can see that there hasn't been a substantial change over that period. Looking more carefully at the specific serotypes that are causing disease in adults, these data are limited to adults 65 and older, although as you saw on the previous slide, our rates of disease from a vaccine policy standpoint, I think our rates of disease in the 50 to 64-year-olds are similar to what they are in the 65 and older. But looking specifically at the 65 and older here, you can see prior to, in the years immediately following PCV13 introduction for infants in 2010, a nice decline in the case count, and most of the serotypes had disappeared by the time of PCV13 introduction for those 65 and older, with the exception of serotype 3. And I think this is something that's been seen in other populations. In our setting, at least, serotype 3 disease is actually increasing, and that's what's really sort of leading to this stabilization or plateau of rates that you see here, is that we've had all of the other serotypes disappear, but serotype 3 has increased. Again, looking at data from Alaska, courtesy of the Arctic Investigations Program, here's PCV13 type IPD in Alaska Native adults, 50 and older, with those 50 to 64 years of age in blue and those 65 and older in gold. You can see, again, a nice decline in the rates of disease following infant PCV13 introduction in 2010, with rates plateauing after that point. When we look at the serotype distribution in Alaskans 65 and older, you can also see a nice decline in the case count following infant PCV13 introduction. And then following PCV13 introduction for adults 65 and older, which, as we discussed earlier, has not penetrated in that population as well as it has in the Southwest Native American populations. You can still see circulation of serotype 3, 4, and 19A. So our conclusions on the IPD data are that substantial indirect effects had been achieved by 2014 to 2015, which left little opportunity for us to be able to assess the impact of PCV13 in adults 65 and older on carriage or on IPD. And I'll wrap up with data on adult pneumonia etiology study that was funded by Pfizer and conducted from March 2016 to March 2018, so also in that era of PCV13 use for adults. This is a case control study. Cases were identified through surveillance at 5 Indian Health Service hospitals, and cases were required to have a provider diagnosis of pneumonia and 2 or more clinical signs and symptoms. Controls were age-matched and were individuals that had no suspicion of community-acquired pneumonia. We collected a variety of specimens, but for today's discussion, I'm just going to be able to focus on the ones that are highlighted in the red boxes. So the blood culture, which was obtained per the clinical team and tested in the Indian Health Service laboratories at the study facilities, and the urine specimen, which was tested by Pfizer for using 2 assays, a serotype-specific urine antigen detection test for 24 serotypes, and the Binax Now assay. The SSUAD1 is a clinically validated and FDA-approved assay for research studies that can detect PCV13 serotypes. Pfizer's SSUAD2 assay adds an additional 11 serotypes. This assay was well characterized but not yet clinically validated at the start of the study. The UAD assay is a limit assay, and for most populations, the published thresholds are appropriate, but there are certain populations for which the values and controls are shifted towards the values that you would see in community-acquired pneumonia cases. That's been seen in children and in HIV-infected individuals. So in this study, we had the opportunity to collect urine from 400 Native American adults in the study community, and then to use the SSUAD results to establish the thresholds for this specific population. And that exercise resulted in us needing to reset the positivity cutoff for serotype 14. We've enrolled over 800 cases in the study, but laboratory testing is ongoing for the second year of the study. So from here on, I'm just going to be presenting the results for the first 355 chest X-ray confirmed cases. Demographics were similar between cases and controls, with 2 exceptions. Females were fairly evenly split. Males and females were fairly evenly split in the cases, but among the controls, we had 74% females. And then another difference was that, let's see if this is catching up, cases were more likely to have a smoker residing in the household compared to controls. When we look at the clinical characteristics, underlying conditions were very common, more so among the cases compared to the controls. And I highlight vaccine coverage here, not necessarily to highlight difference between cases and controls, but just to point to the high vaccine coverage that we see in this population. So among those less than 65 years of age, you can see 66% of cases had received polysaccharide vaccine and 48% of controls, with smaller percentage having received PCV13 for risk factor indications. And then among adults 65 and older, over 90% had had polysaccharide vaccine, and over 80% had had PCV13 vaccine. So turning now to the results among chest X-ray positive cases with any pneumococcal test performed. You can see the strep pneumococcal positivity by test with the different tests listed along the x-axis here. These data are stratified by age, with all ages in red, 18 to 64-year-olds in blue, and 65 and older in gold. And overall, pneumococcus was detected in 26% of community-acquired pneumonia cases. The SSUAD increased the detection of pneumococcal cases by 57%, and there was 100% serotype concordance between SSUAD serotype and the blood culture serotype. Because there have been concerns in the past about specificity of urine assays, we wanted to compare the urine test results among our chest X-ray positive cases and the community controls. And you can see that the SSUAD was positive in 19.5% of cases compared to 2.8% of controls. And Binax was positive in 15.5% of cases compared to 3.2% of controls. So while specificity is not perfect, it's excellent for these assays. The serotype data were available for 72 of the 91 pneumococcal cases that were detected, and a third of them were PCV13 type. You can see the serotype distribution in the figure on the bottom, which is stratified by age, with 18 to 64-year-olds in blue and those 65 and older in gold. And you'll note that for the PCV13 type cases, the vast majority of those are serotype 3. If you exclude serotype 3, then we're just left with 4 or 6% being PCV13 type among those pneumococcal cases. To compare with the data that Dr. Swerdlow just presented overall in the study, PCV13 types were responsible for about 6% of overall overall community-acquired pneumonia admissions. Among those PCV13 type cases that had vaccination status available, 62% of them had received PCV13 in the past, and all of those had received PPV20 first and then PCV13. And so we'll go into that in a little bit more detail on this slide. This just looks at the PCV13 type cases among adults 50 to 64 years on the top, adults 65 and older on the bottom. And now I'll direct you to the legend. You can see the top entry on the legend is receipt of PCV13 before PPV23, which is the recommended sequence and is shown in the bright green bars. You can see that there's no bright green bar on the graph, which means that nobody received that recommended sequence. And this isn't a matter of the IHS providers not following recommendations. This is a matter of the IHS providers having done a really, really good job of vaccinating people who are at high risk with PPV23 prior to the advent of the ACIP recommendations for PCV13 in adults. And so you can see the vast majority of these cases had received PPV23 before PCV13. Many of them had received more than one dose. And I think better understanding is needed of the implications of the order of vaccination on the immune response. And obviously a lot more work is needed to understand the impact of the vaccine on serotype 3 disease, both at an individual level and a population level. So pneumococcus remains a really important cause of chest X-ray positive pneumonia among Native American adults. Non-PCV13 serotypes and serotype 3 predominated. The SSUAD assay was really useful and increased the detection of pneumococcal pneumonia over conventional methods. It did not reveal a substantial burden of PCV13 type disease, with the exception of serotype 3. But of course, this is in the context of high PCV13 use in both infants and in adults 65 and older. And with that, I'd like to acknowledge, most importantly, the Navajo, White Mountain Apache, and Alaska Native communities who have graciously welcomed us to work in their communities, and the thousands of study participants who've engaged with us over many years now, as well as Center for American Indian Health faculty and staff, the various IRBs that oversee all of the research we do, as well as the tribal health boards and tribal councils that guide the work that we do. This work wouldn't be possible without our Indian Health Service, clinical and laboratory partners. We also partner with the Arizona and New Mexico Departments of Health, the Navajo Epidemiology Center. Thank you to Mike Jacobs, who did the culture and serotyping for our carriage studies, to Pfizer for their collaboration and funding a couple of these studies, and to our longtime collaborators, the CDC's Arctic Investigations Program in Anchorage. And I'm happy to take questions if I've left enough time.
Thank you very much. That was terrific. Questions for Dr. Hammett? Perfect. Dr. Stevens.
Can't let you get off the stage without a question. Are you doing molecular typing on your isolates in particular, given the replacement issues we've seen previously? What is it? I mean, serotype can be helpful, but the molecular typing can be more informative. Can you tell us anything about molecular typing? And I'm particularly interested in serotype 3s. Are they, can you tell us about those?
We're particularly interested in that too. And we've just, one of my colleagues at Center for American Indian Health just received a Robert Austrian research grant to actually do some molecular characterization of our serotype 3 isolates. We've done this previously in collaboration with colleagues at Harvard, Mark Lipsitch, and Taj Azarian's lab. And we've seen similar patterns there that we've seen in other places with the change between clade 1 and clade 2. And we don't know that was from several years ago, and we're now looking to look at those isolates again to see what's circulating and what's perhaps causing what we view as an increase in serotype 3 disease right now. More to come.
Dr. Gravenstein.
Hi, John Gravenstein from Merck. Dr. Hammett, thank you for the presentation. The Indian Health Service has had a great PPSV23 program for many years. So you showed people getting P23 first and P13 second. Are you able to assess the interval in time between the two vaccinations? Because it could be a considerable number of years.
Yeah, we do have that data, and I've looked at each one of these cases. In many cases, 70% of the people who'd had their polysaccharide vaccine prior to their PCV13 vaccine had multiple doses of polysaccharide vaccine ahead of time, and the interval, varies quite a bit. So, some people are having their first vaccine for polysaccharide vaccine back in the 1990s and have had, 3 vaccines prior to getting their PCV13. So we do want to take a little bit more careful look at what those intervals look like and see if that can help inform on what's going on. Thank you.
Okay, thank you so much. It's great. Dr. Matnott.
Good morning. Thank you very much. Going the wrong direction, I guess. So IPD rates have historically been higher in some racial minorities. Race is sometimes used as a proxy for socioeconomic status, but in terms of risk for disease, SES might not account for all of the differences in IPD incidence between races. An alternative theory is that some of the increased risk among people of Black race is driven by higher prevalence of chronic medical conditions such as sickle cell disease and HIV. Depicted here is the most recently published analysis using active bacterial core surveillance, or ABC's data, for children less than 5 years old. The first time point on the horizontal axis depicts the IPD incidence by race pre-PCV7 introduction. Overall, at this time, there was approximately 100 cases per 100,000 population absolute difference in IPD incidence among children of Black race as compared to white race, which corresponds to a rate ratio of 2.5. At the last time point, just before PCV13 introduction, the absolute difference has been reduced to approximately 20 cases per 100,000 with a rate ratio of 2.2. Our objective in this analysis was to evaluate the racial disparities in IPD since introduction of PCV13. We used ABC's data from the 10 active laboratory and population-based surveillance sites. Pneumococcus was isolated from sterile sites. Race was defined as a single race reported in the medical chart. Race was imputed for the 13% of IPD cases where it was not recorded from other patient characteristics such as age, location, syndrome, and underlying medical conditions. U.S. Census population estimates were used as denominators. Isolates are serotyped by Quellung or PCR at reference labs and grouped in the following ways for analysis. For children less than 5 years old, there are PCV13 types, which include 6C due to cross-protection, and non-PCV13 types. For adults, we have an additional category of PPV11, the 11 unique serotypes in PPSV23, and then all other non-vaccine types. We compared overall and serotype-specific IPD incidence before and after pediatric PCV13 introduction. This table shows the distribution of race and the major invasive syndromes caused by pneumococcus. In the first column are the numbers listed for those less than 5 years old, and the second column, those greater than 65 years old. There are differences between the age groups. This graph displays the trends in IPD incidence from 2008 to 2016 for children less than 5 years old. PCV13 type is in gold, and non-PCV13 types are in black. Solid lines represent cases amongst children of Black race, dotted lines amongst those of white race, and the hashed lines are all others. So looking just at PCV 13 type IPD here, the incidence reduced for all children after PCV 13 introduction. And I'd like to point out the absolute incident rate difference between children of Black and white races went from 8.5 in 2008-2009 to less than 1 case per 100,000 in 2015-2016, with an unchanged incidence ratio of 1.8 to 1.7. Looking at just the non-PCV 13 serotypes here, the incidence over time has remained stable, with similar disparities between groups. When including a relatively higher incidence year of 2008 and a relatively lower incidence year of 2016, there appear to be some reductions in the absolute rate difference in IRR, but overall there does not appear to be any increase or decrease in the trend. This graph displays the trends in IPD from 2008 to 2016 for adults 65 years and older. Again, PCV types are in gold, and here is added the unique 11 PPSV23 types in blue, and again, non-vaccine types are in black. Solid lines represent cases among adults of Black race, dotted lines amongst those of white race, and the hashed lines are all others. From 2010 to 2014, the majority of adults 65 years and older were only experiencing indirect or herd effects from pediatric vaccination. After the PCV13 recommendation in 2014, there are combined indirect and direct effects for adults 65 years and older. So looking just at the PCV13 type IPD here, the incidence reduced for all adults after pediatric PCV13 introduction. The absolute rate difference between older adults of Black and white race went from 2.1 in 2008-2009 to equal in 2015-2016, with an unchanged incidence rate ratio of 1.1 to 1. The unique PPSV serotypes over time are different from the PCV serotype disease in older adults in that there has not been a dramatic decrease in incidence, but the incidence by race is similar and relatively unchanged from 2008 to 2016. Among non-vaccine type disease in older adults, the incidence has been stable over time, but there remains a persistent gap between older adults of white and Black race, with those of Black race consistently experiencing at least 5 cases per 100,000 more than whites, with an IRR of approximately 1.5. This table summarizes the previous graphs, shows the absolute rate difference and incident rate ratios among persons of white races not listed here because they are used as the reference group. In gold is the PCV13 type incidence comparisons, and in purple is all IPD incidence comparisons. Again, PCV13 type absolute rate difference between children of white and Black races went from 8.5 in 2008-2009 to 0.8 in 2015-2016. The decline in PCV13 type IPD drove a reduction in the absolute difference between whites and Blacks from 17.8 to 5.5 in all IPD. Looking at adults 65 years and older, PCV13 type absolute rate difference went from 2.1 to equivalent between Blacks and whites. However, with a significant proportion of the remaining non-PCV13 type disease, the overall IPD incidence was similar in 2008-2009 to 2015-2016. Please note that these numbers have been corrected from those in the printed handouts, just for this line of total IPD, the absolute rate difference. Our preliminary conclusions for this analysis are that, as with other analyses, we observe IPD dramatically declining after pediatric PCV introduction for all race groups, driven by reductions in PCV13 type IPD. PCVs have nearly eliminated the absolute difference in PCV13 type IPD incidence between people of Black and white races. The disparities in IPD that remain are due to non-vaccine type IPD, which we see especially in older adults. Further analysis is planned to look at the contribution of SES as well as underlying medical conditions by race. I would like to acknowledge and thank the many people involved in gathering this data and doing this analysis. And if it's okay with you guys, I'll pause here for questions on this portion before moving on to discussing the ETR.
Questions? Yes, Dr. Bernstein.
It was interesting that you imputed race. Is that a multiple imputation and it's only 13% of the IPDs? Is there a reason to do that, or do you look at it without the imputation? Or?
Yeah, and actually we do look at it both ways without the imputation. We just impute to make it more complete for the entire set, and it is multiple imputation. But yeah, it does. I think it always strikes everybody as a little bit odd to do that, yeah. Yeah, and in future we can present it both ways, and if you want, without the imputation.
Dr. Paradiso.
Peter Paradiso. I just wanted to point out for the non-pneumo mavens in this group that it's a really interesting result in the U.S. that there's been this dramatic reduction in the vaccine serotypes without a significant increase in replacement with other serotypes, either in the over 65 or in the children. Whereas in many other countries, they're fighting this replacement disease very significantly, and it's the thing that makes it interesting scientifically is that we vaccinate with 3 doses in the first year and a dose in the second year, whereas many other countries use a 2+1 schedule, and you'd actually expect perhaps the reverse, where a greater reduction in carriage might lead to more replacement, whereas it has not. And so, this has been a very successful program, and in part because we haven't seen that replacement, and it's a lot of people trying to figure out why that disparity, but we're benefiting from that success, I think.
Thank you. Dr. Bresnitz.
Ed Bresnitz from Merck. Just a quick question. Could you provide some context here by giving us some estimate of the percentage of individuals who had been vaccinated with PCV13 between 2014 and 2016 and who then received PPV23 as per the recommendation?
Thanks. I'll have to look that up, and what I'm looking up for your reference as well is the MMWR that was published. The lead author is Carla Black last year. And let me just pull out those numbers. There is a difference in vaccination rate overall. For this, I'm talking about older adults. Obviously, since PPSV 23 is not in the standard recommendation for children. But let me just pull out those numbers. And probably even better to send you to that reference. But let me see. Aha. So it's as everybody I think here knows, it's difficult to look at adult vaccination because we don't really have any standardized registries, and how we obtain that information through the multiple different channels has its limitations. So this MMWR looked at Medicaid beneficiaries 65 and older with claims submitted for pneumococcal vaccination. And there they saw between those of black race and those of white race a 10% difference. So at that time point, 33% of blacks had been vaccinated with 1 dose of PPSV and 44% of whites. 1 dose of PPSV was 33% in whites and 19% in blacks. So again, a noticeable difference between the two. And receiving both PPSV 23 and PCV was 19% amongst whites and 10% amongst adults of black race. However, to completely get at your question, Eddie, the order and timing of those vaccines is not known from this source.
Thank you. Dr. Atmore.
So at the beginning of your presentation, you set up the possibility that the racial disparities in incidence might be either related to as a surrogate of socioeconomic status or due to actual racial differences. But I guess my interpretation of the data you presented is that as the incidence of PCV13 disease has declined, those differences, racial differences have disappeared. And I can't tell whether you actually answered the question, but whether it was due to socioeconomic status or race, but it appears that as the disease has disappeared through direct effects in pediatrics under 5 and maybe indirect effects in other age groups, it's not really relevant what the reason is. Am I missing something?
No, I thanks a lot for that clarification. That sort of got lost. I guess I brought that up because we are still planning to look at this by socioeconomic status, and we know that there have been different results seen depending on if you look at it by race or by socioeconomic status. And I made that point because I didn't want it to get lost that one could be a complete proxy for the other. I don't think that should be sort of the framework we're working in. But I do think that the overall message is that through vaccination, sort of whichever one of those things is causing any of the difference for PCV13 type IPD with the vaccination program that we have in place, the disparity in absolute difference of cases by race has pretty much been eliminated. Okay. So we'll move on. So just as a reminder, these are the elements of the ETR framework. There needs to be a statement of the problem, the benefits and the harms, the values and preference of the target population, acceptability of the proposed policy change to stakeholders, resources used, including cost-effectiveness analysis and feasibility of implementing the policy. To reiterate what Grace said about the current adult PCV13 policies, in 2012, PCV13 was recommended in series with PPSV 23 for adults 19 years and older with immunocompromising conditions, asplenia, cochlear implants, and cerebrospinal fluid leaks. In 2014, an age-based recommendation was added for PCV13 to be given in series with the previously recommended PPSV 23 for all PCV-naive adults 65 years and older. In 2014, there was a commitment to reevaluate this recommendation given the ongoing indirect or herd effects, which brings us to today and the question. Should PCV13 be administered routinely to all immunocompetent adults 65 years and older, given sustained indirect effects, with the supporting PICO elements of population of immunocompetent adults 65 years and older, intervention of CV13 at 65 years or older in series with PPSV23 in the context of indirect effects, and the comparison being PPSV23 alone at 65 years and older, what was being previously used before 2014, and the outcomes of pneumococcal disease mortality and vaccine safety. As part of the ETR, we are considering the following outcomes as part of the grade process: PCV13 type IPD, non-bacteremic pneumococcal pneumonia as measured by all-cause pneumonia, NBPP, and PCV type pneumonia, mortality due to IPD and NBPP, and serious or systemic event associated with PCV13. Within this framework, the information that has been added today includes safety data for PCV13 among adults. No new safety signals or unexpected patterns have been observed in VAERS surveillance, and no increase in adverse events were observed in the VSD cohort. We will continue to monitor and provide updates as needed. Pneumococcal pneumonia still causes a relatively high burden of disease, especially when looking also at IPD, relative to IPD. As presented today, from June 2014 to May 2016, PCV13 type pneumonia in adults 65 years and older decreased. However, this observation is limited to only 2 years. Additionally, as discussed before, the time period after 2014 is difficult to disentangle direct and indirect effects. The proportion of pneumonia caused by PCV13 serotypes was 4% among adults 65 years and older in Louisville and 6% among American Indian adults in the Southwest. In Louisville, 66% of pneumonia incidence was in adults 65 years and older was in patients with immunocompromising conditions or HCAP. Population characteristics and case definitions contribute to variations in pneumonia incidence. Studies estimating all-cause pneumonia and pneumococcal pneumonia incidence and vaccine impact are anticipated in October. Pediatric PCV introduction has reduced racial disparities in IPD. IPD incidence has dramatically decreased for all racial groups, driven by reductions in PCV13 type IPD, nearly eliminating the absolute difference in PCV13 type IPD incidence in people of different races. Carriage of PCV13 serotypes in American Indian children and adults are similar to the pediatric and adult carriage studies presented here last October. Among American Indians in the Southwest during UNES, 26% of chest X-ray confirmed pneumonia was caused by pneumococcus, but PCV13 serotypes did not predominate. Our tentative timeline going forward is to share outstanding data at the upcoming meeting in October. These include PCV impact on all-cause pneumonia and MBPP from studies examining administrative and clinical surveillance data, and the potential public health impact. And I'd like to say here, as Dr. Paradiso asked in an earlier presentation, this public health impact will be for both pneumonia and IPD and based on all of the available evidence. And cost effectiveness will be a part of that as well. We hope to have the ETR with grade finalized by the following meeting in February and anticipate a potential vote in February, or if additional time is needed, in June 2019. So again, we are working to reevaluate the 2014 PCV recommendation for adults 65 years and older, with the question being, should PCV13 be administered routinely to all immunocompetent adults 65 years and older in a setting of sustained PCV13 indirect effects? For this, I'd like to now open to discussion about what additional information is needed both here and for the grade. Thank you.
Thank you for that very nice summary. Questions? Comments? Yes, Dr. Moore.
Thanks. I think as we go forward, I think actually Dr. Hammett's presentation brought to mind the fact that the vaccine includes 3 but doesn't really work very well against serotype 3. It would be incredibly helpful wherever possible in further discussions to look at the burden of vaccine preventable disease, sort of what's remaining that's serotype 3, so that we can really understand that if we retained a direct vaccine program, how much would we expect to affect overall vaccine types, because we're probably not going to affect much about the serotype 3, even if we maintain vaccination, although it's included in the vaccine type. So had I thought of it when Dr. Swerdlow was talking, I would have asked what percentage of the remaining disease is serotype 3 that we're seeing that we could actually do something about or not. But going forward, I would love to see that whenever it's possible. Thanks.
Thank you.
So can I ask a question of the questioner?
Sure.
Of course, go ahead.
So maybe just to make sure I understand correctly, is then the assumption there that the perhaps that the serotype 3 disease we're seeing, whether that's increasing or just remaining, I think has been discussed both ways here, that is because of a lack of indirect effects or a lack of direct effects?
A lack of direct effects. So that if we're trying to decide whether or not to retain a recommendation for immunocompetent older adults, what amount of disease remaining do we think we could actually prevent with that policy? Because we don't think we could really prevent much in the way of serotype 3 with that policy. Does that make sense?
Got it.
We got
so
it.
For all others, not serotype 3. Thank you.
Yeah, what's preventable, essentially, and serotype 3 probably not being preventable by any strategy at this point. Dr. Stevens?
Related to that question is the next generation of pneumococcal vaccines. There is now talk of an expanded PCVs, and can we hear more about? I'd like to hear more about that from the perspective of our discussions and deliberations. That would be one point. Second point is about when to give a conjugate vaccine. There's obviously giving it at 65, and in one case we saw here in the 90s, may not be the best strategy. Should we be thinking about when we give a conjugate and when you boost with a polysaccharide, for example, at a younger age? So those are two things that I would like to see.
Other comments? Yes, Dr. Lee.
Just, it was really helpful to have those presentations, even though I've heard them before. It was really helpful to have them side by side again. For me, because it illustrates the challenge we have in disentangling really the direct effects from the indirect effects. In Dr. Swerdlow's presentation, it seemed like perhaps that there were some potential direct effects, despite it being a very overall less than 50% vaccination rate in that population. In contrast, Dr. Hammett's presentation, I thought, really illustrated that despite really high vaccination rates, there was really no gain after 2014 in terms of IPD, and that was predominantly because of serotype 3, but it's helpful to have all of this information in one place, so thank you.
Yeah, I agree. This was a terrific presentation, really outstanding. Before we end this session, though, I have to comment on one thing. Many of you probably realize that it's Dr. Cindy Whitney's last meeting with us. And for me personally, this is particularly painful because I really feel like all my work with the CDC started with Cindy. So but more than that, I think she's been an incredible leader of the pneumococcal group. I think that the work that the pneumococcal group has done has been extraordinary over the last 10 years, and we really have to thank her for her tremendous leadership, and you will be so sorely missed.
there's definitely nothing more I can say after that. Thank you.
Well, we're very happy about the new generation also, and thank you for all your hard work. So, thank you so much. It was a great, great session. Vaccine supply, Dr. Santoli.
Hi, I have a very brief update for the last slot in the meeting. I'm going to talk about hepatitis A vaccine and hepatitis B vaccine, both adult and pediatric, and then I'm going to remind you about our supply webpage. So for adult hepatitis A vaccine, during 2017, as this group is very well aware, there were a number of large outbreaks among adults in several cities. There was a lot of demand for vaccine, more so than historically, and supplies were constrained. A number of actions were taken that we've talked about here between CDC and public health officials in affected jurisdiction to target the vaccine according to local epidemiology. Ordering controls were implemented to keep equitable distribution in place for unaffected jurisdictions, and CDC's contracts were modified to make more vaccine available. In addition, both manufacturers increased the amount of vaccine available in the U.S. market. Wrong way. Vaccine continues to be directed toward the jurisdictions who are affected by outbreaks. And in addition, as supplies have improved, the vaccine supply strategy has evolved and more vaccines being made available for routine use and or prevention activities in jurisdictions that don't have large outgoing outbreaks. But we're still very closely monitoring in conjunction with the manufacturers the demand for and usage of this vaccine. For adult hepatitis B vaccine, as you know, Merck is not currently distributing its adult hepatitis B vaccine or the dialysis formulation and will not be distributing vaccine through the end of 2018. GSK has indicated they have sufficient supply of adult hepatitis B vaccine to address the anticipated gap, although specific preferences for presentations may not be met during this period. In terms of pediatric hepatitis B vaccine, Merck is not distributing its pediatric hepatitis B vaccines. That began in mid-2017 and is anticipated that that will continue during 2018. Together, however, so they'll continue to have a limited supply during 2018. I apologize for misstating that. But together, both manufacturers are able to supply the U.S. market. And there's approximately 10% less of the monovalent pediatric hepatitis B vaccine compared to normal. This expected monovalent supply is fortunately sufficient to cover the birth dose for all children, and it does provide some vaccine for second and third doses. There are also, as you know, combination vaccines that are meeting the rest of the need for hepatitis B vaccine in children. So CDC has implemented ordering controls using both Merck's vaccine and GSK's vaccine. And in addition, GSK is providing monovalent vaccines to the private sector, aligned with the clinical guidance for emphasizing and continuing with the birth dose. And then again, as I said, GSK's combination vaccine Pediarix continues to be available in both sectors. And as a reminder, this is the web page where we try to keep everyone abreast of updated information. I usually update it after this meeting to make sure everything's in sync with what we've shared here. Thank you very much.
Thank you. Any questions for Dr. Santoli? Yes.
So this is Schaffner from NFID. Just a footnote to Dr. Santoli's remarks regarding adult hepatitis B vaccine availability. It might also be mentioned that we have another recently approved hepatitis B vaccine available, that's Heplisav.
So that's true, and the website at the point when these updates came up, that vaccine was not an option, but as we're updating it this time, we'll certainly make note of that. Thank you very much.
Thank you. Any additional questions or comments? Okay. We now have several public comments. Dr. Cohn?
Great. So I will call out the members of the public who signed up for public comment. And if you guys could speak in the order in which I call you out, that would be great. Brittany Vallis is the first speaker, followed by Andrea Woodruff, Rebecca Hastings, and Lynette Barron. And those are the 4 names I have. If I didn't capture your name, then please go see Stephanie Thomas in the back. So, Ms. Vallis?
Hello. Okay. Thank you so much for everything everybody is doing and for the wonderful presentations and for explaining to everybody what you guys have been working on for such a long time. I did have a couple of questions about the JE vaccine and the presentation with that earlier, and I just wanted to you guys aren't able to answer the questions, but I wanted to give a comment and maybe a line of thought to see what your thoughts would be on that. So my understanding is that there were 12 cases of JE in about a 19-year span. So in those 12 cases, that boils down to less than 1 case per year. So if we're looking at that, you also mentioned that the death rate in JE is 33% in 1 case. So in less than 1 case per year, the possibility of dying is about 33% of that. So, the purpose and the idea behind vaccines is to save lives. So I'm going to focus on the high risk group, which is the risk group 1, which is recommended for all travelers staying over a month, and also focusing on the death on that as well. So 12 cases over the course of 19 years, 33% chance of dying in that less than 1 case. So in that situation, it would take 2,230,284 people to be vaccinated to save that potential 1 life. So if we're looking at that, and then we also look at the cost standpoint at the higher rate, and I apologize, I don't have that number down here, but I'm sure, $292 per vaccine, you're looking at $651 million, $242,928 to potentially save that 1/3 of 1 life, less than 1 life, who's actually contracting JE, in that possible year. So we're looking at that cost, and then even with the reduced cost of vaccine at $131 per vaccine, then you're looking at $292,167,204 of vaccinating that number of people to potentially save that 1 life that might get it in 1 year. So we're looking at that as far as cost goes. And then one other thing I wanted to point out is that you mentioned that there are 64,000 cases of JE in Asia that have not been vaccinated. And 2 things. Number one, we're looking at a population of, I think, 4 or 5 billion people. So the chances of them even getting it not being vaccinated, we figured up as 0.000, there's like 5 zeros. So the chance of them getting it is extremely, extremely rare, even without the vaccination. And then, as you mentioned, the people that are in that area, they receive natural immunity from the symptoms of getting it whenever they do get it. So I wanted to mention those 2 things. And then the next aspect of it, you mentioned the boosters. We're not really sure how efficacious it is. And I noticed that the efficacy really went down as far as the number of boosters. It definitely doesn't, it wears off, it doesn't last. So when you're looking at people to return to this country and possibly getting the disease, then my question becomes, wouldn't it be better for them, if they even get it, to achieve natural immunity through getting those basic symptoms, and then they have their immunity for a lifetime, versus maybe getting a booster shot or not getting a booster shot? So I wanted to present that as one idea. And then the second idea, in looking at the study, you're comparing vaccine to vaccine as far as the safety profile and the adverse events. So my first thought is, if you're comparing to those 2 vaccines, I would want to know from the second vaccine, what's the safety event profile on that vaccine in comparison to an inert saline placebo, and comparing it in that way, because we don't really know, like, what if this vaccine has a ton of adverse events? we're not really looking at how safe this vaccine is if we're comparing it to another vaccine that could potentially cause a lot of adverse events. So basically, at the end of the day, I understand that this might be an inconvenient illness for that less than one person, maybe a year that might get it, that really is probably not going to die from it. But is this vaccine even needed? I mean, is it even necessary? And to go through the cost of having to produce this and then to require or strongly recommend for that class 1 of people that's staying over there for a month to get this vaccine when we don't even really know the safety profile of it because you're just comparing it to another vaccine, that's a lot of unanswered questions. And when you're looking at the general public, when they're going to this other country and they're being told, you might get this, you might get this, you might get this, they're just going to, follow suit. And we really don't know the safety profile, and the disease is really not a big deal. So I just wanted to see if not vaccinating would be an option.
Thank you very much.
Okay.
Next up.
Mr. Andrew Woodruff.
Hi, and thank you. With the Center for Disease Control organization, I've always been pretty impressed with. But I'm starting to really doubt how much we can control disease. I think at best we can manage it. I've been watching data issues, been asking for models, but I haven't gotten them. I've been reading about strain replacement, recombination of viruses, recombination of bacteria, contamination issues, manufacturing issues. These things seem to be out of our control. I think we can try to manage and we can report what is being found, but it ultimately comes down to my choice as a person and as a parent, what my data points are and what I'm seeing. And I'd love to hear your information, and I'm grateful that you provide it. But I don't think we can control it. I think we need to look at these things a little differently. Thank you so much. Take care.
Thank you.
Hi, I'm Rebecca Hastings, and I'm in here on my own in my private capacity, paying my own expenses. And I really appreciate the opportunity to have this public comment. And at the risk of beating a drum and making music that no one wants to listen to, I hope to narrow my comment a little bit today. So my guess is that probably everyone in this room understands the priority and significance of breastfeeding. Some of you theoretically, and some of you have had personal experience, either yourself or someone close to you, with a breastfeeding mom and baby, a healthy diet, just getting it right. Well, as a breastfeeding counselor, trying to help thousands of moms over 25 years, I often see moms really struggle, and some of their main struggles have to do early on with latching, and that often prevents them from developing a good milk supply. And so over the years, I've looked at this and I've noticed, and I've read some studies that point a correlation between early Hep B vaccine and difficulty with breastfeeding. And non-vaccinated babies often do better with breastfeeding. And so could early hepatitis B, that birth dose, be playing a role in sabotaging the breastfeeding of newborns? Further, Dr. Yao's study using animal models notes a long-term impact on the brains of mice that received early vaccination with Hep B. And that caused a neurobehavioral impairments, not right away, but in early adulthood. So the original Hep B studies prior to the inclusion on the schedule tracked infants for less than 2 weeks. Amongst a growing incidence of anxiety, violence, and social disorders amongst the youth in our country today, it is no small thing to review the long-term impact that this routine shot may be having on our children. I understand there are many branches in the CDC, and you're all looking at various aspects of health. And I'm sure you have specialists who are working to improve breastfeeding rates and trying to understand the anxiety, depression, violence, and suicide rates amongst youth. And increased communication amongst these various branches of the CDC may increase our understanding of the complex, non-specific effects that could be associated with vaccines. And for the layperson, that's unintended consequences. So the vaccine schedule currently has 3 categories to which physicians refer regarding administration of Hep B. Positive mothers, negative mothers, and mothers of unknown status. I would suggest that to delay the hepatitis B vaccine for negative mothers, at least until breastfeeding is well established, would be a great idea. And I'd also like to have more representation in your working groups from people who are studying non-specific effects, experts such as Dr. Christopher Exley, Dr. Teresa Deischer, Dr. Mawson. These people can inform your working groups just as you currently have the pharmaceutical industries representing their work and their studies in your working groups. And I think that will give you the evidence base. Many have said here today, you don't have enough evidence. You are making decisions without evidence. Well, there is evidence available, and I think if you access it, it will be better for everyone. Thank you.
Thank you. Next up.
Hello, my name is Lynette Barron. I'm here representing my children. I have 2 vaccine-injured children. I had no idea vaccine injury was even a possibility. I have 5 kids. Always followed the schedule. My 3 oldest ones that I didn't, never even imagined it could happen. When my 4-year-old was 15 months old, I took her to the doctor for thrush. I did not take her in for vaccinations that day. I took her in because she was sick. The doctors told me that my child had to get vaccinations that day. And I told them I did not think this was a great idea because she was in there for thrush. Which I'm not a doctor, I'm not a scientist, but I have, Google, I can read that means your immune system is down. But they kept telling me that if my child was able, would get something that she could have had that would have been prevented by those vaccines, then I would be in trouble. So that I needed to go ahead and do this that day. So my daughter got 6 vaccines that day. 2 were triples. From that day forward, we went through 26 days straight of fever. We spent 7 weeks in children in Birmingham. We had bone marrow aspiration and biopsies. We went through all kinds of, anyway, sorry, it's just really hard when you're a parent and you have to go through this. I give my daughter Neupogen injections now every 3 days of her life, and I have ever since this happened. 2 weeks prior to her injury, I cut my finger. 2 tiny little stitches is what I needed. I was 26 weeks pregnant, and I was told that I had to have a Tdap vaccine. I received that Tdap vaccine. Her 2-year-old sister has severe autism, global development delay, epilepsy, gut issues. The list goes on and on. I can't even tell you how many diagnoses this child has received, and she's not even 3 years old yet. I have 5 kids. My kids, my older kids didn't get a schedule like this, and we didn't see problems like this. The schedule keeps growing and keeps growing and keeps growing, and you're creating people like me. I don't want to have to know all this vaccine science. I don't want to have to read every book about this stuff, every medical journal. I'm a mother. Seriously, I have turned my entire life around in order to try to help other people avoid the same pain my family has to go through. And if y'all had all the proper science, like this sweet woman just said, from actual scientists other than just the people who are being paid to do these things, pharmaceutical companies aren't thinking about people like me. They're not thinking about those children who don't need to be vaccinated again. They're not thinking about, I'm sitting next to Paul Offit earlier, the same man who says if you're not going to vaccinate your children, they should be taken by the state. I will never vaccinate my children again, and the state will not come take my children because I will fight tooth and nail for my kids. This is not the way this should be. You shouldn't feel pressure to do something like this. You should have all the proper information. If y'all don't have all the science, then how will we have all the science? It just doesn't make any sense. I really hope that I will be at every meeting that comes. I will be right here. I really hope that things start getting better and the science actually starts improving, because the saddest part is I hear more data that makes more sense about what's going on everywhere else than I do in this room. So I just really hope that that actually improves for people like us who we don't want to have to do this. We don't want to be in your space, in your face. You know, I want to be at home with my children. I had to pay over $500 to make this trip today to come here from out of state just to talk to you guys, to let you know we don't want to be, forced to do these things, or we don't want to be told it's okay when they're sick. It's okay. We do this all the time. It's not going to do anything. And if you don't want to do it and something happens to them, then you're responsible. Who's responsible when something happens to my children? Nobody, because they deny them from vaccine injury compensation program. Nobody cares. They don't want to hear your story. They don't want to hear it. They told me, find my own expert, find my own lawyers. How do I find my own experts? Somebody please tell me that. I mean, it's just insane. The system is not set up to help people. It's damaging, and it's just, it needs to stop.
Thank you.
Hello again, Tia Severino. I just want to say the hepatitis B vaccine was one of the vaccines that injured my son. When he was brought to me after a 5-hour delay after an emergency C-section, he could not latch. He could not nurse. I ended up having to supplement, even though it was my desire to exclusively breastfeed him. I thought I was going to take the cautionary approach to vaccinations. He only received 4 vaccines. 4 individual separate vaccines separated by 3 to 4 weeks. And he still ended up injured, okay? I'm sitting here listening to you guys talk about a shortage in the hepatitis B vaccine for newborns. And I, for the life of me, cannot understand why you are recommending this vaccine for a sexually transmitted disease for day 1 old infants. And I would like to point out for this panel that the United States has the highest day 1 infant mortality rate in the world. Why? We're supposed to have the best medical system in the world. Why are more babies dying the first day of life here in this country? Why do we have the highest rates of infant mortality? We have the highest vaccination rates. We should not have children dying. Babies go in at 2, 4, and 6 months and are routinely injected with up to 23 antigens. I'm standing right here representing a friend of mine named Priscilla and her husband Will, whose daughter died after receiving her 4-month vaccines. This was determined to be caused by vaccines. Now, with the hepatitis B vaccine, by the time my son is sexually active, guess what? That vaccine's not going to be protecting him. It lasts maybe 8 to 10 years. So you're telling me that I needed to inject my newborn child with a sexually transmitted disease vaccine that it's going to wear off before he's ever even sexually active? It makes no sense to me. If you guys are worried about a shortage in hepatitis B vaccines, why don't you just stop giving them to babies? Then you'll have more to go around. Thank you.
Thank you. With that, I think we've completed all that signed up for public comment, and I think that we've completed the June 2018 ACIP meeting. Thank you all so much.